So we're going to go ahead and move on to our next speaker, and that's going to be Shannon Monnat, and from Syracuse University's Maxwell School of Citizenship and Public Affairs, who will be presenting up on the associations between states' COVID-19 physical distancing policies and working age adult mental health outcomes. Shannon, it's up to you.
Okay, great. Can you see my slides? Perfect. So today I'll just tell you a little bit about some results from one of our UL1 papers that considered associations between different states' COVID-19 physical distancing policies like business closures and stay-at-home orders, and a handful of self-reported mental health outcomes among working age adults. This is the investigative team. So these are the PIs and co-investigators and our postdoc who recently started working with us, and we have a graduate research assistant as well. So we're fully staffed and ready to go on this project. So these are the overall UL1 aims, and I won't spend much time here because if you've been to the spring meeting, you've seen these before, but our first aim is to use a nationally representative sample of US working age adults to try to understand how states' COVID policies are associated with psychological well-being. This is a survey that I'll talk to you a little bit more about later this afternoon. So these are individual level outcomes for aim 1. Aim 2 is to examine how those same sets of COVID policies affected county level mortality rates from fatal drug overdose and suicide. And then aim 3 is to collect additional waves of the survey that we're using for aim 1, which we first collected before we got funding for this project. So we'll collect 4 additional waves over the next 4 years to identify longer term relationships between states' policies and other contextual conditions on adult psychological health. So today I'll show you results from one part of the first aim. This particular paper, what we're trying to do here is to determine associations between physical distancing policies at the state level and working age adult self-reported mental health outcomes. Another part of this first group of papers is to test a Bayesian group index modeling approach that really accounts for the reality that states enacted multiple types of policies at the same time in ways that may cumulatively impact mental health. So people live in more than one policy at the same time, whereas most research and papers try to assess the effects of individual policies. The outcomes come from, as I mentioned, the first wave of the National Wellbeing Survey. This is a national cross-sectional survey of geocoded survey of adults that are aged 18 to 64. It's administered through Qualtrics panels. And we collected this first wave in February and March of 2021 before we submitted our UL1. So the outcomes capture a period about 1 year into the pandemic in the US. Now, when weighted, the NWS is demographically representative of the US population ages 18 to 64. And we've done some quality comparison work with other surveys and have found that the prevalence rates on these data on several health conditions and COVID-19 outcomes are comparable to other national surveys. For these analysis I'm presenting today, we considered 4 outcomes. We captured them all dichotomously. So we look at a variable we called worsened mental health. And this is based on the prompt of overall, please rate how the COVID-19 pandemic has affected the following aspects of your life. And we gave them a whole bunch of things, and mental health was one of them. So people who responded with substantially worsened or somewhat worsened, we dichotomized those with a value of 1. And then a second question asked about which of the following experiences did you have as a result of COVID-19 related closures or other social distancing policies? And we asked about seeking treatment for anxiety or depression. So individuals who indicated that they did that are coded 1. So those 2 variables directly assess people's perceived impact of COVID-19 on their lives. We also assessed anxiety and depression using the clinical thresholds from the PHQ-4 questionnaire. And they don't directly assess COVID-19 impact, but they ask about depression and anxiety symptoms in the past 2 weeks. And then our models control for a basic set of demographic covariates from the NWS. We also control for the county's cumulative COVID-19 death rate at the time the respondent completed the survey. And that's to account for the severity of COVID in the respondent's residential area. This just shows you weighted percentages of respondents who reported adverse outcomes. You can see here that about 38% reported that their mental health worsened due to the pandemic. So again, this is that question where respondents attribute the causal attribution to COVID. Just over 18% reported seeking treatment for anxiety or depression due to COVID-19 related business closures or other social distancing protocols. And nearly 2/3 met the clinical thresholds for anxiety or depression in the past 2 weeks. Our exposures are 12 state policies that are designed to reduce spread by reducing interaction with people outside of one's household. And we considered different ways of operationalizing the policies, but we settled on cumulative days of exposure based on the date the policy was enacted and the date the policy ended, or the date the respondent completed the survey, whichever came first. So this figure shows the percentage of respondents ever exposed to each policy in parentheses. And you can see that for many of these, nearly everyone was exposed, right? So a simple binary measure of ever being exposed wouldn't be all that useful for analysis like these. And this is one of the reasons we settled on days of exposure. The bars show the average number of days of exposure among those who were ever exposed. So the zeros aren't included in these means. These are the means among people who were ever exposed to policy. So, bar closures are by far the longest exposure that people had on average. We ran 2 different types of models. Our first step was to model associations between each of the separate policies and the 4 mental health outcomes. And these just use basic binary logistic regression models. Standard errors are clustered at the state level, and we control for the set of covariates I presented earlier. Now, because a single day of exposure produces a very small effect size, we're going to show results using month as the unit of exposure. So the odds ratios will represent the difference in the odds of the outcome for a month of exposure. But as I mentioned earlier on, state policies cluster. So states that enacted one type of policy were more likely to enact another type of policy. And we can't include all of the policies in the same standard model because then we'd have some serious multicollinearity problems, right? So in the second step of our analysis, we use a Bayesian group index approach to model associations between the policy indices and the mental health outcomes. These models estimate weighted indices of these correlated policy variables and their association to the outcome. And what I'm going to show you today, we're presenting results based on quartiles to scale the policy days and the indices. So for these analysis, a 1 unit change would mean moving from one quartile of exposure to the next quartile of exposure. One of the benefits of the Bayesian approach is that the importance of the weight of each policy on the outcome is estimated from the models themselves, and the policies aren't assumed to have equal weight. So the data drive the weight that is assigned to each policy. So forget about the Bayesian models for now. We're just going to go back to the binary logistic regression models that estimate the association between each separate policy and the 4 outcomes. This figure shows the odds ratios with 95% confidence intervals for each model. Again, these models control for the covariates listed earlier. The unit of exposure is 1 month. So just looking at the first 2 panels, we can see that none of the single policies are associated with odds of anxiety or depression. But there are some policies that are associated with the other 2 variables. And these are the 2 that ask explicitly about COVID-19 impacts. So business curfews and non-essential retail closures are associated with significantly greater odds of reporting that COVID-19 worsened your mental health. And exposure to gym, movie theater, and bar closures are associated with significantly greater odds of reporting seeking treatment for anxiety or depression. So thinking about these results that I just showed, we can see the challenge with modeling policy effects in this way, because we know that exposure to things like gym closures, movie theater closures, bar closures are highly correlated. So the coefficient on one of these policies in an individual model is picking up on the effect of other policies that are correlated with that policy. But because of this correlation, we can't just throw all of the policies in one model to figure out what matters most. So making an index solves this problem. The Bayesian index approach can handle these multiple correlated policies. Again, the weights of the different policies on each outcome aren't assumed to be equal. And you can set up the models, and we did after the first step, to not assume that all policies are associated with the outcome in the same way. So some might have a negative association, some might have a positive association. Turning to this index approach, we did first include all 12 policies in one model. See what happens. So this shows the odds ratio for a 1 unit increase in the index. Again, a unit here is a quartile. So moving from one quartile to another of exposure. These models are accounting for the simultaneous influence of all 12 policies, along with the control variables. And here we find a significant association between the index and seeking treatment for anxiety and depression. And we kind of approach statistical significance for the outcome of worsened mental health. So the interpretation here would be that moving from one quartile on the index to the next quartile is associated with about a 10% greater odds of seeking treatment for anxiety or depression, and about 7% greater odds of reporting that COVID-19 negatively affected your mental health. In terms of which policies are driving this finding, and this is one of the really nice things about the index approach, is that we can identify which policies weight most highly in these indices. We see that closing gyms and business curfews had the largest weight on the index related to seeking mental health treatment. And then several of the policies contributed very little to the index. Their weight is low on this figure. We don't show here the weights for the index of policies that were associated with reporting negative mental health outcomes, but there we find that business curfews and closing other non-essential retail contributed the most to the index associated with that outcome. But those models included all 12 policies, regardless of the direction of their potential association with the mental health outcomes. So the next step was to separate the indices based on the direction of their univariate association between the policy and the mental health outcome. It's possible that some policies have an adverse association while others are what we could call protective or have a positive association. So this shows that policies did group into two indices. One group that's positively associated with outcomes and one that's negatively associated with outcomes. But only the indices with the positive associations, meaning they made the outcome worse, were significant. And that was only for seeking treatment and for the adverse mental health impact. There's still nothing happening with anxiety or depression, even in these models. So just as an example, we found that moving up a quartile in the index of these adverse policies, these policies that increase the odds of the negative mental health effect, was associated with about 25% greater odds of seeking mental health treatment and 23% greater odds of reporting that COVID-19 worsened your mental health. More days of exposure to a very small group of policies, what we kind of refer to as protective, is associated with lower odds of adverse mental health outcomes, but those weren't statistically significant. So what are these policies? Well, this is showing the policies that grouped into the positive and negative indices. Again, remember that the negative indices weren't significant, right? So really we're paying attention here to the positive indices. So for the adverse impact of mental health outcomes, closure of non-essential retail and the business curfew contributed the most weight to that outcome. Closing gyms, movie theaters, daycares, restaurants, they also contributed to the index that increased the odds of reporting that COVID-19 worsened your mental health, but much lower weight. For seeking treatment for anxiety or depression, closing gyms and business curfews loaded the highest, but not that much more highly than the other policies. So for that outcome, exposure to other non-essential business closures, stay-at-home orders, daycare closures ended up in the protective policy index. And again, while not statistically significant, that's the group of policies that we can think of as maybe being associated with lower odds of reporting seeking treatment for anxiety or depression. So to wrap up, we aren't calling these conclusions because we still have some work to do. We have some explanations to figure out for why we're seeing what we're seeing. We need to sort out whether we want to use quartiles or 30 days, a month of exposure as our exposure unit, so all kinds of decisions to make. But our general takeaways, no matter how we run these models, is that among working age adults, even 1 year into the pandemic, some individual physical distancing policies do appear to be associated with reporting that one's mental health worsened. In particular, people live in multiple policies at the same time, and that's not considered in models that assess effects for individual policies. And we did find that bundles are associated with greater odds of seeking treatment for anxiety and depression and reporting adverse mental health outcomes. And we think that what's going on is that business curfews, gym closures, non-essential retail closures, they seem to be playing the largest role in those two adverse mental health outcomes. And the Bayesian approach allows us to sort of tease out the weight of those relative to the other policies, because as I mentioned earlier, you can't just throw all of the policies in a single logistic regression model, because then you wouldn't be able to tease out the multicollinearity problem. This is how we identify these specific policies that we think are having the largest association. So I will wrap up there and look forward to hearing questions and suggestions from the group.